And you can see this has increased in the face of other chronic diseases decreasing, and unfortunately it's increasing more steeply in the Asian population, who are the majority of the audience today. So we also recognise that there's a very high rate of unrecognised disease in people with type 2 diabetes. So if we look at kidney disease, approximately 97% of people with stage 1 or stage 2 kidney disease don't know that they've got it. That accounts for the majority of people with kidney disease. But if we look at stage 3 kidney disease, which is an EGFR of the overall kidney disease burden. And probably what's more worrying, although it's a lesser total number of patients, almost half of the people with stage 4 or 5 chronic kidney disease, where the guidelines say we should be educating people about dialysis and renal replacement therapy, 46.7% don't know they've got kidney disease. Similarly, if we look at heart failure, 28% don't realise that they've got heart failure when they're screened on a background of having type 2 diabetes. So we know that glucose control isn't enough. When we look at all of the, the glucose target outcome studies, we can see that there's a benefit in microvascular disease outcomes. And in the short term, there is no benefit in cardiovascular disease outcomes. If we extrapolate a longer period, there is a reduction in cardiovascular outcomes, but this isn't always sustained, as was shown in the ACCORD study. And mortality is a very mixed picture. It doesn't demonstrate uniformly a reduction in mortality. So we can surmise from this data that glycemic control is effective in reducing microvascular complications, but paradoxically increase mortality, particularly in vulnerable populations as were involved in the ACCORD study. So we've known that blockade of the renin-angiotensin system improves renal and heart failure outcomes. And we've known this from the studies dominantly from the RENAL study and the IDNT study, where there was a reduction in the composite kidney outcomes, which were doubling of serum creatinine in end-stage kidney disease. But also that there was a significant reduction in heart failure hospitalizations. But worryingly, and this is US data, so it's not Asian data, people are not coded for having disease, and a significant minority of people receive little or no pre-end-stage kidney disease nephrology care. Almost half of the people don't have a urinary albumin test, and only 20% of people were appropriately prescribed ACE inhibitors or ARBs, despite evidence now for over 20 years that these do reduce kidney and cardiovascular outcomes. So pleasingly, in the last 5 to 6 years, we have had outcome studies looking at a fairly new class of agents, the SGLT2 inhibitors. And thankfully, we've got a very broad spectrum of these trials that have included the cardiovascular outcome studies. People with chronic kidney disease with the composite endpoint being directed to reduction in hard kidney endpoints, heart failure studies, and then more recently we have the DAPA-CKD study that looks at chronic kidney disease outcomes in people with and without type 2 diabetes. And we're very much looking forward to the EMPA-KIDNEY study that will be reported next year that broadens the applicability, or may broaden the applicability of this class of agents to people with chronic kidney disease at a greater range of GFRs with and without albuminuria. So if we look at the cardiovascular outcome trials, we can see that people with atherosclerotic cardiovascular disease have been greatly benefited. There was a 34% reduction in these hard cardiovascular endpoints across all of the SGLT2 inhibitor agents within the class. So empagliflozin here reduced the cardiovascular endpoints, largely nascent cardiovascular death, by 34%, the CANVAS program by 23%, and declared TIMI by 17%, overall giving a very strong class effect for the SGLT2 inhibitors. It wasn't quite as strong in the population that had multiple risk factors but no established disease, but certainly there is a signal for benefit, and the p-value for interaction is not different. If we look at the Asian versus the Caucasian participants, you can see that the Asian population in the cardiovascular outcome trials strongly benefited by the SGLT2 inhibitors, with a very similar effect to the Caucasian population. If we look at the heart failure studies, again, we can see that the Asian population, again, is perhaps, if anything, numerically more benefited than the Caucasian population. But overall, there's no significant difference, and we can be very confident that the Asian population are benefited from cardiovascular MACE outcomes, cardiovascular events, as well as heart failure with the use of these agents. If we compare the SGLT2 outcome trials, each of the trials tell us something slightly different. So if we look at the cardiovascular outcome trials, which are the EMPA-REG, the CANVAS, the DECLARE, TIMI, and VIRTUS, you can see in each of these trials there were differences in the number of people who were enrolled with various degrees of renal dysfunction. So about 15 to 20% of people in EMPA-REG and in the CANVAS program had an eGFR between 45 and 60, lesser numbers in dapagliflozin, and about 20% in VIRTUS. And again, you can see that there's about 25% who had microalbuminuria, lesser numbers with macroalbuminuria. If we look at credence, we can see that 100% of people had macroalbuminuria, about a third of people had an eGFR of less than 45. And then if we turn to the DAPA-CKD study, we can see that 44% of people had an eGFR of less than 45, and 14.5% had an eGFR of less than 30. So you can see each of these studies tell us slightly different things in terms of their outcomes. But if we look overall at the studies, we can see that there is a class effect in reducing the risk of composite kidney disease endpoints in patients with type 2 diabetes. So a 46% reduction in achieving the kidney endpoint with empagliflozin, a 40% with canagliflozin, 47% with dapagliflozin, and 34% again in the renal specific outcome study of Credence. So if we look at Credence, this was the first renal outcome, dedicated renal outcome study, and it demonstrated a 30% reduction in end-stage kidney disease, doubling of serum creatinine, renal or cardiovascular death. And the secondary endpoints, which were cardiovascular, were positive for cardiovascular death and hospitalisation for heart failure, MACE indications, hospitalisation for heart failure independently, renal-specific outcomes, And then we get to cardiovascular death, which didn't reach statistical significance with a p-value of 0.0502. So the subsequent analyses were not considered valid, although you can see that this expanded MACE endpoint was also positive. So if we then look at the meta-analyses as for the SGLT2 inhibitors in reducing progression of kidney disease, we can see that the studies in the canagliflozin program were all positive. We can see that the studies in the dapagliflozin studies weren't so statistically positive with respect to the DAPA-HF study, but were positive with DECLARE and also positive with DAPA-CKD. This study, there wasn't a p-value for interaction, although it did cross unity. We look at empagliflozin, and we've got the EMPA-REG cardiovascular outcome study, and also the EMPEROR-reduced heart failure study, both of which were very strongly positive for reducing the progression of kidney disease. And ertugliflozin didn't meet statistical significance, but on the secondary endpoints for renal outcomes, it did. But we can't be sure about ertugliflozin. So then the CANVAS study has the canagliflozin data has the benefit of the CANVAS study in people who had pretty much preserved kidney function, an eGFR of 76 mils per minute, and a low urinary albumin to creatinine ratio. And then also the CREDENCE study, which were people with stage 3 kidney disease and macroalbuminuria. So you can see here the people who were allocated to the canagliflozin had very stable kidney function if they were started on the treatment early, whereas people who were allocated to placebo had a progressive reduction in eGFR over time. If we look at people who were started on the intervention later, when they had a lower GFR, more significant albuminuria, you can see that there was a progressive decline in kidney function in those allocated to placebo, lesser decline in those allocated to canagliflozin, but a decline still occurred. So the message from this is that we need to detect people with kidney disease early and intervene early where we can stabilise kidney function rather than just slow the progression of kidney disease. So if we look at DAPA-CKD, we can see that there was a reduction in the primary endpoint. We can see that the secondary endpoint of a reduction in renal-specific outcomes was actually also reduced. And if we look at that study, this gives us some information about people with and without diabetes as the cause of their kidney disease. And you can see that independent of whether or not people had diabetes, pre-diabetes or normoglycemia, there was benefit in each of these outcomes, the primary outcome, the renal-specific outcome, and death was, obviously broader confidence intervals, but no significant difference between the groups. So if we look at the timing of when we intervene, we can see that there's a benefit for intervening when the GFR is preserved, so an eGFR of greater than 90. And we can see from the CREDENCE, the CANVAS and the EMPA-REG study that there's also benefit in intervening when the GFR is less than 45 mils per minute. And what we've understood now from the DAPA-CKD study, as I've said, these appear to be very much a class effect, is that stage 4 CKD also has a significant benefit in slowing the progression to the primary endpoint. Albeit not statistically significant because there was 600 patients rather than the 4,000 or more patients, but no significant p-value for interaction, and certainly the benefit is in favour of the SGLT2 inhibitor. Now, I think people also wonder about diuretic use. Is this a problem? And we have that information from DAPA-CKD in patients who had more significant kidney disease as opposed to the cardiovascular outcome trials. And you can see here the people who were treated with diuretics had overall an increased risk of an adverse event. They probably had more heart failure, they probably had more comorbidity compared to people who weren't treated with a diuretic. But you can see dapagliflozin doesn't cause an increased risk in terms of adverse events. If anything, it tends to be lower, both in patients with and without diuretic use. Similarly, MRA use is now of interest, particularly given the Fidelio study. And again, MRA use was excluded in patients in the Credence study, but there were a small number of patients, 100 in each group, who were given MRAs with dapagliflozin, and again, no increased risk of adverse events. So now if we look at the population that we have information about, this green bar here is the cardiovascular outcome studies. So people with pretty much preserved kidney function, we know that we can protect them from developing kidney dysfunction. If we look at Credence, we can see that these are largely the people with macroalbuminuria with a range of GFRs. We look at DAPA-CKD, again, largely albuminuria, more than 200 milligrams per gram, and with a range of eGFRs down to 25 mils per minute. And where we're going to get additional knowledge is in the EMPA-Kidney study, which hopefully we'll report next year, which looks at people with an eGFR down to 20 to 45 mils per minute who have no albuminuria. So a completely unique population, in addition to people with stage 3B up to stage 2 chronic kidney disease with background albuminuria. So we're very keen in awaiting the EMPA-Kidney study. So why do SGLT2 inhibitors protect against renal dysfunction? And we know that they protect in both diabetic and non-diabetic kidney disease. And this is because the mechanisms of progression are not specific to diabetes or to a specific form of kidney disease. They are pretty much similar across the board. So, we know if we lower albuminuria in diabetes, in glomerular disease, etc., we know that oxygen consumption is important. I'm going to discuss some of these processes in the next few slides. So I'd just like to introduce tubuloglomerular feedback. I'm sure many of you are completely across tubuloglomerular feedback, but this is the mechanism whereby the kidney regulates the filtration of the single nephron, basically to maintain, extracellular volume status. So if the kidneys recognises that there's an increased sodium being sensed at the macula densa, it sends a signal to constrict the afferent arteriole and reduce the single nephron GFR. So that protects the nephron, the individual, from losing too much salt. Similarly, if there's a reduction in sodium that's seen at the macula densa, this is a signal for the GFR to rise and potentially enable it to secrete more salt by virtue of increased filtration. So sensing of the sodium at the distal tubule is really key to regulating glomerular filtration and hence intraglomerular pressure. So this is a slide that I have taken from my PhD, and it's very unusual that you're able to talk about your PhD some 30 or more years later, where I micropunctured diabetic animals, and I determined that in animals with diabetes, there was an increase in sodium reabsorption along the nephron up to the early distal site. So in effect, a low sodium was being sensed at the distal tubule, which would increase GFR and cause glomerular hyperfiltration. And that's exactly what I demonstrated. In the whole animals, there was an increase in filtration. And when I administered Florazin, which is a precursor of the SGLT2 inhibitor class, it normalized this hyperfiltration and glomerular hypertension back towards the normal animal GFR. I also demonstrated in cell culture that high glucose exposure to the proximal tubule increased sodium-hydrogen exchange, so a further mechanism for increasing sodium reabsorption along the nephron. So you can see there was an increase in the transporters, and there was an increase in the translocation of the transporters to the proximal tubular membrane, the apical membrane, to allow increased sodium reabsorption. So what we recognise is under the normal state, sodium is sensed at the macula densa, and this regulates GFR. In diabetes, we recognise that there's an increase in sodium glucose reabsorption, but also an increase in sodium hydrogen exchange that also increases sodium reabsorption, and that contributes to a low sodium at the macula densa and therefore an increase in glomerular filtration. If we use an SGLT2 inhibitor, it obviously reduces SGLT2 reabsorption, but stoichiometrically it inhibits sodium hydrogen exchange activity that then increases delivery of sodium to the distal tubule, activates tubuloglomerular feedback, reduces glomerular hyperfiltration, and reduces glomerular hypertension. So we can see here that the SGLT2 inhibitors deliver more sodium, reduce the single nephron GFR, which provides renal protection. We also recognise that in diabetes, these mechanisms to increase sodium transport increase intracellular sodium concentration. And again, this is something that I studied during my PhD and demonstrated that there was an increase in intracellular sodium in the proximal tubule of the diabetic animals, which can then trigger mechanisms that cause hyperplasia and hypertrophy, either through ion transport mechanisms or the triggering of cytokine responses that contributes to hypertrophy that we recognise as being integral to diabetic nephropathy. We also recognise that when we develop chronic kidney disease, hypoxia occurs in the kidney. And this is demonstrated by this bold MRI where we can see that there's lower oxygen tensions in patients with GFRs that are less than 65 compared to more than 65. Given that we inhibit sodium transport in the cortex, this limits oxygen requirements and improves the oxygen delivery and therefore improves oxidative stress and various other mechanisms in the cortex of the kidney with chronic kidney disease. So we recognise that reduction in cortical sodium reabsorption then results in an increase in distal sodium delivery, which then results in increased sodium reabsorption, swapping for potassium, and there's less hyperkalemia that's demonstrated with SGLT2 use. And that's been accepted for publication. It's been demonstrated in all of the SGLT2 studies. We also recognise that because there's reduction in sodium reabsorption proximally but increased distally, then there's paradoxically a medullary hypoxemia that actually then triggers EPO production, because it's in the medulla that the pericytes sense the oxygen tension and then produce EPO. So people treated with SGLT2 inhibitors have a higher hemoglobin, which we regard as being beneficial in people with chronic kidney disease. We also recognise that autophagy is impaired in diabetic kidney disease. Now, autophagy is the process whereby damaged subcellular organelles, including mitochondria, which is then termed mitophagy, digested by the cell, and then in a process of catabolism that generally occurs overnight, and then during the day in the fed state, then anabolism occurs and there's regeneration of these organelles. So we recognise that SGLT2 inhibitors can drive this catabolism rather than allowing this autophagic flux to be blocked, and therefore a build-up of rubbish inside tubules and inside the kidney cells, because it drives this catabolic state. It results in a shift from energy from the use of glucose to free fatty acids, which is a much more efficient energy fuel, and it improves this anabolic biogenesis of functional organelles and proteins, which results in a healthier organ overall. It also reduces sympathetic outflow, so it decreases the renal afferent nerve tone, and because of the mild ketosis generated by the increasing glucagon to insulin ratio, it decreases the sympathetic outflow to the kidney, so it reduces sodium reabsorption and activation of the renin-angiotensin system, and it reduces the sympathetic vasoconstriction of blood vessels, so thereby improving vascular outcomes, and also decreases the sympathetic outflow to the heart, which results in improved cardiac outcomes. Now, we recognise that this interaction between heart failure and impaired renal function is very strongly recognised clinically. They have underlying common mechanisms, and abnormality in one organ drives abnormality in another organ. So SGLT2 inhibitors have been studied in the setting of heart failure. So there have been several studies, DAPA-HF, Emperor Reduced, and Soloist, which have used different types of SGLT2 inhibitors. These have all been done in people with reduced left ventricular ejection fraction with a varying degree of kidney dysfunction. If we look at Emperor Reduced, which had the best outcomes in terms of kidney outcomes, we can see that the primary outcome, which was a heart failure outcome, first adjudicated cardiovascular death or hospitalisation for heart failure, strongly positive 25% reduction in this primary outcome. We can see that if we look at the secondary outcomes, which were the first hospitalisation for heart failure, similar to DAPA-HF and Emperor Reduced, if we look at first kidney outcomes, it was more strongly positive for the empagliflozin with a 48% reduction in the development of the first kidney outcome. And similar for the first and recurrent hospitalisation for heart failure. If we look at the benefits in people with and without diabetes, because both DAPA-HF and Emperor Reduced included people with and without diabetes, the benefits were across the board. So, similarly, equally beneficial whether or not diabetes was present, and similarly equally beneficial if the GFR was less than 60 versus more than 60 mils per minute. So again, if we look at the Emperor-Reduced study, it met its primary endpoint, it met its key secondary endpoint, which was a heart failure endpoint, as well as the secondary endpoint, which was the benefit in slowing the rate of decline of kidney function. So these are people now looking at the primary endpoint in people with and without chronic kidney disease, and you can see it didn't matter whether people entered into the study with or without chronic kidney disease, as determined by a GFR of greater than or less than 60. There was equal benefit in heart failure outcomes. If we look at the improvement or the slowing of progression of kidney disease, people who entered into the study with or without kidney disease had a marked slowing of the rate of progression in reaching a composite kidney outcome. So if we try and put the SGLT2 inhibitors in context of what the other I guess proven benefits are for Paradigm, and ARNI, and compare it to DAPA-HF, you can see that the SGLT2 inhibitors, particularly for the empagliflozin studies, have a marked benefit in reducing the composite kidney secondary endpoint. Dapagliflozin, which was purely people with chronic kidney disease, also demonstrated a positive endpoint. If we look at the people who entered into the study, we can see that the benefits are more marked for people who are over the age of 55, which is probably not surprising because people with heart failure under the age of 55 often have a complex background for the cause of their heart failure, congenital heart disease, cardiomyopathy, etc., rather than ischemic or microvascular causes for heart disease. People worry about the development of acute kidney injury, and this is data from the EMPA-REG study, where it was demonstrated that those who are allocated to treatment with empagliflozin had about a 2.7-fold increased risk in developing a initial dip in their GFR. And that was predicted by worsened kidney function at entry and by the use of diuretic therapy. But when we look at whether or not that actually was then portended a future problem with kidney disease, you can see that whether or not people had a greater or a less than average decline in their kidney function, they still had a benefit in favour of the use of empagliflozin, both on incident and worsening nephropathy and on hard kidney outcomes. And in fact, a reduction in acute kidney injury has been shown in all of the cardiovascular outcome and renal outcome studies now. So I think this acute drop in GFR is physiological, it's protective, and it doesn't suggest people are going to end up with long-term acute kidney injury. So we should note it, remeasure it, but not necessarily modify any therapy. I just thought it was worth a slide or two on the use of finerenone, because this has been now published in the Fidelio study, where they looked at people with type 2 diabetes treated with the aldosterone antagonist finerenone and demonstrated an 18% reduction in renal outcomes with the use of finerenone, as well as a 14% reduction in cardiovascular event rates. So it raises the issue as where do the MRAs fit in with the SGLT2 inhibitors? And the best data that we have is from the Emperor-Reduced study, because in people with heart failure and reduced left ventricular function, obviously MRAs are indicated. So there's a large number of people who are treated with MRAs at baseline, and we can see that there's still a benefit in favour of empagliflozin in people who were treated with MRAs at baseline that's very similar to those who were not treated with MRAs at baseline, both for the primary event and the key secondary event. And if we look at the forest plot on all-cause mortality and cardiovascular death, there's no significant difference, but there is a trend for a benefit in favour of the use of MRAs in conjunction with empagliflozin. We don't have data in the kidney population. We've got very minimal data from the DAPA-CKD study, where there were a couple of hundred people who were treated with MRAs compared to those who weren't treated with MRAs. Numerically, there is a similar benefit, although because of the small numbers, those treated with MRAs didn't have a statistical benefit with the use of concurrent dapagliflozin. But you can see that the magnitude of benefit is numerically similar. So on the basis of this data, the guidelines have been modified. So the European Society of Cardiology now recommend that in people who have atherosclerotic cardiovascular disease and type 2 diabetes who are not on any therapy, their first therapy should be an SGLT2 inhibitor or a GLP-1 receptor agonist. In people who are on metformin, who have, a high cardiovascular risk, then they should be, an SGLT2 inhibitor should be added independent of their glycemic control. If we look at the kidney guidelines, then it does suggest that metformin should be used if possible, but if not, then use an SGLT2 inhibitor in preference to any other agent. And only if the hemoglobin A1C is above target, then add in a GLP-1 receptor agonist and then other medications. And KDIGO suggests that for people with type 2 diabetes and chronic kidney disease, if the GFR is above 30, then we should simultaneously prescribe metformin and SGLT2 inhibitors, and only subsequently add in a GLP-1 receptor agonist. So hopefully I've addressed these issues that I've suggested I'll discuss, and I'm very happy to take questions. Thank you.
Okay, thank you, Professor Pollock. So I would like to ask some questions. Is there any difference in renal benefit between GLP-1 receptor antagonists and SGLT2 inhibitors? Because both have some beneficial effect in prevention of CKD or cardiovascular disease.
At the present time, very much in favour of the SGLT2 inhibitors. The GLP-1 receptor agonists do show a reduction in albuminuria, but not a convincing reduction in the slowing of the rate of decline in kidney function. So that's why the various bodies such as KDIGO and the EDTA have suggested that SGLT2 inhibitors be used in preference to the GLP-1 receptor agonists. There is the FLOW study that hasn't reported with the specific aim of looking into whether or not the GLP-1 receptor agonists may well reduce renal outcomes, but as yet we don't have that evidence. So as it stands, the evidence sits with the SGLT2 inhibitors.
Okay, thank you. And another question is, currently we have CREDENCE and DAPA-CKD. And EMPA kidney is ongoing, right?
Yes.
What is the interesting point from EMPA kidney from your point of view?
Well, as I mentioned in my talk, EMPA kidney is interesting because it includes people with a lower GFR without albuminuria. And so people would be aware that there haven't been any studies, for instance, using ACE inhibitors or ARBs that have demonstrated benefit in people without albuminuria. And the SGLT2 studies that have demonstrated benefit have largely had people with significant albuminuria. So I'm very interested in this group of people with low GFR, no albuminuria, to see whether or not the empagliflozin affords benefit. That, I think, is the unique aspect of the study. I fully expect that the study will probably demonstrate benefit in people with a higher albuminuria, independent of the GFR. But I think, as I mentioned, each of these studies, add to the body of knowledge, and I think EMPA kidney is going to expand this body of knowledge to people with kidney disease without significant albuminuria.
Okay, another question is, as EMPA kidney extend from diabetic to non-diabetic CKD and include non-proteinuric patients, how can we expect SGLT2 inhibitor benefits from this study from non-diabetic CKD?
Well, I think I tried to explain why the benefit might include people with and without diabetes and with and without albuminuria in some of the mechanistic studies. So, for instance, hyperfiltration at the single nephron level occurs when nephron dropout occurs because of hypertension, ischemic disease, various other background kidney problems. And then the nephrons that are left are hyperfiltering. So if we can protect those nephrons by virtue of causing afferent arteriolar vasoconstriction, then, ultimately, hopefully, the endogenous kidney function lasts longer. So I don't think it's dependent on albuminuria, and I think it's not dependent on having diabetes. So that's why EMPA kidney will provide more information about those groups and hopefully allow us to use these class of agents in those groups where we really have had no therapeutic options really forever. We've had the ACE inhibitors, the ARBs, more specifically for the last 20 years, but for non-proteinuric kidney disease, there's been very little that's evidence-based. So if we can develop the evidence that comes out of EMPA kidney, it would be fantastic.
Okay, Wasit, if we use the SGLT2 inhibitors in our patients, what is the cost effectiveness of this agent in prevention of this CKD or CVD? Have any study demonstrated the cost effectiveness of these drugs?
Look, there are some studies that are in abstract only, as far as I've seen, and it does very much depend on the jurisdiction where people work. So there is a Discover CKD study that looks at Japan, Europe, and the US, and looking at the cost benefit, it seems that there is a significant cost benefit in the fact that you reduce dialysis costs, you reduce hospitalizations, you reduce heart failure, reduce myocardial infarction. But look, it's very dependent on what the payers, accept as being cost effective. So we, myself and other colleagues are putting in a health economic modelling discussion to ISPOR, which is the health economic, international conference towards the end of this year, looking at some modelling as to how to demonstrate cost effectiveness. I think when you look at the an individual who has time off dialysis, the effectiveness is enormous, independent of the cost. And obviously there's a payer component here, and the government view might be different to the patient view. But I just know that my patients are incredibly, what they basically want is not to be on dialysis. And that's what the SGLT2 class of therapy does. It gives them time off dialysis, gives them time without heart failure and without significant cardiovascular morbidity and mortality.
Okay, so and another question is that when we use SGLT2 inhibitors, and we know that the risk of AKI increased with diuretic use. In practice, do you stop diuretic treatment before starting SGLT2 inhibitors or not?
Look, I think it depends on the clinical situation. I tend to stop or reduce the dose and then reintroduce it, because I think that the original studies were done, I don't know how many people remember when we first started using ACE inhibitors, but they had to be given in hospital because people were on high doses of diuretics and they would get markedly hypotensive. And I think there's been a learning curve with the SGLT2 inhibitors such that people with autonomic neuropathy, background high uses of diuretics, potentially the combination of MRAs, do tend to get hypotensive with SGLT2 inhibitors. Now, sometimes that's a good thing. We want to lower the blood pressure, but early on, I do tend to stop or reduce the dose of the diuretic and then reintroduce it. Because people come back into sodium balance after 48, 72 hours. So I think it's a good idea to stop it at the beginning and then reintroduce.
Okay, in your countries, who treats CKD patients apart from nephrologists? Internist or GP, or who take care of the kidney patients and who prescribe SGLT2 inhibitors?
Well, as I showed you in that data that suggested that people who had preserved kidney function, they did very well with SGLT2 inhibitors in that their kidney function completely stabilized. Now, they're not the people that kidney doctors see. They're people that GPs see, or that data came from the Canvas and Credence study. So they're people that endocrinologists would see. So I think that it really needs to be used by primary care physicians to prevent kidney disease, rather than, by the time people get kidney disease, then we introduce it and all we can do is slow the rate of progression. Whereas what I would like to see is prevent kidney disease rather than slow the rate of progression, where still kidney disease, end-stage renal failure is going to be an inevitability. So I'm thinking it should be used primarily by everybody really, but early stage kidney disease or diabetes without kidney disease to prevent the development of it.
So at this stage, do you use SGLT2 inhibitors in CKD stage 3 or stage 4? what the GFR limit, the lowest one?
So in the Credence study, they used canagliflozin above a GFR of 30 and then continued it till people ended up on dialysis. So they didn't start at a GFR less than 30, but they continued till dialysis. There was a secondary analysis of people that actually did start at a GFR lower than 30. There was about 160 people. They demonstrated a benefit in that sub-analysis. In DAPA-CKD, they started at less than 20 or at 25 or above. And I think I mentioned there were 14% of people who had a GFR of less than 30. They also continued, and in the DAPA-CKD study, they were able to continue whilst the person was on dialysis. They didn't stop when they reached end-stage kidney disease, although there were very few that took that option, maybe 100. So unable to really demonstrate whether or not there was a benefit in continuing the dapagliflozin once people had started dialysis. I think that's an interesting question. At the moment, the data isn't available for starting an SGLT2 inhibitor if the GFR is less than 25. We'll get that data from EMPA-Kidney down to 20. But certainly if people have started on an SGLT2 inhibitor with a GFR above 25, they should continue it until they end up with end-stage kidney disease.
Okay, I think we ran out of time. So we'd like to thank Professor Carol Pollock and the audience and Berlinger Company for supporting this symposium. Thank you very much. And now the session is closed.
Thank you very much.
Thank you very much.